Hello everybody, and welcome to my presentation on adolescent girls and eating disorders. Modern American culture portrays mixed messages about the human body. Our society often projects the stick-thin image of a catwalk model as the ideal representation of health, success, and happiness for a woman. These images, combined with numerous advertisements for diet and exercise programs following those for fast food, sugary cereals, and soda, cause much confusion in people's minds, especially young, impressionable girls. While there are numerous types of eating disorders recognized in the DSM-5, I will only be focusing on 3 for this presentation, the first of which being anorexia nervosa. Anorexia nervosa is an eating disorder characterized by weight loss or lack of appropriate weight gain in growing children, difficulties maintaining an appropriate body weight for height, age, and stature, and, in many individuals, distorted body image. People with anorexia generally restrict the number of calories and the types of food that they eat. Some signs of anorexia include a distorted view of one's body weight, size, or shape, sees self as too fat even when underweight, restricting, hiding, or discarding food, obsessively counting calories and/or grams of fat in the diet, denial of feelings of hunger, developing rituals around preparing food and eating, compulsive or excessive exercise, social withdrawal, pronounced emotional changes such as irritability, depression, and anxiety. Some physical signs of anorexia nervosa include rapid or excessive weight loss, feeling cold, tired, and weak, thinning of hair, absence of the menstrual cycle in females, and dizziness or fainting spells. Teenagers with anorexia nervosa often restrict not only food, but relationships, social activities, and pleasurable experiences. Here we have some visual representations of what someone with anorexia may see versus what is actual reality. The second type of eating disorder that I will review in this presentation is bulimia nervosa. Bulimia nervosa is a serious, potentially life-threatening eating disorder characterized by a cycle of binging and compensatory behaviors such as self-induced vomiting designed to undo or compensate for the effects of binge eating. Someone suffering from bulimia will often be seen eating unusually large amounts of food with no apparent weight change, hiding food or discarded food containers and wrappers, excessive exercise or fasting, peculiar eating habits or rituals, frequent trips to the bathroom after meals, inappropriate use of laxatives, diuretics, or other cathartics, overachieving and impulsive behaviors, and frequently clogged showers or toilets. Some physical signs of bulimia include discolored teeth, malodorous breath, stomach pain, calluses or scarring on the hands caused by self-inducing vomiting, irregular or absent menstrual periods, and weakness or fatigue. Teenagers with bulimia nervosa often have a fixation with body weight and shape, as well as a distorted body image. The clinical diagnosis commonly points to bulimia nervosa if an individual binges and purges on average of once a week for at least 3 consecutive months. This chart shows the binge-purge cycle that most bulimics engage in, starting with strict dieting, then moving on to having their diet slip or a difficult situation arises, which then triggers the binge eating. Then purging happens to avoid the weight gain from the binge eating. Feelings of shame and self-hatred occur after the purging has happened, and they return back to the strict dieting. And it is a vicious cycle that is incredibly difficult to break. The third type of eating disorder I want to discuss is binge eating disorder. Binge eating disorder, or BED, is a severe, life-threatening, and treatable eating disorder characterized by recurrent episodes of eating large quantities of food, which is often done very quickly and to the point of discomfort, a feeling of a loss of control during the binge, experiencing shame, distress, or guilt afterwards, and not regularly using unhealthy compensatory behaviors such as purging to counter the binge eating. It is the most common eating disorder in the United States. BED is one of the newest eating disorders formally recognized on the DSM-5. Some signs of binge eating disorder include eating an unusually large amount of food within a distinct period of time, typically 2 hours, hiding food or discarded food containers and wrappers, eating in secret because of feeling embarrassed by how much they are eating when stressed or when feeling uncertain on how to cope with life, feeling that they are unable to control how much they eat and disgusted with themselves afterwards, experimentation with different diets as well. Some of the physical signs associated with binge eating disorder are typically more long-term, which includes weight gain, high blood pressure, diabetes, irregular menstrual cycle, skin disorders, and heart disease. Similar to bulimia nervosa, binge eating disorder is commonly diagnosed if teenagers binge on average once a week for at least 3 consecutive months. Here are some photos of what it may look like and or feel like for someone with BED. What is important to remember is that with BED, it is more than just emotional eating. It is also about control as well. Next, I would like to review some general statistics in eating disorders. Eating disorders affect at least 9% of the population worldwide. 9% of the U.S. population, or rather 28.8 million Americans, will have an eating disorder in their lifetime. Less than 6% of people with eating disorders are medically diagnosed as underweight. 28 to 74% of those who are at risk of developing eating disorders, it is typically through genetic heritability that it will happen. Eating disorders are among the deadliest mental illness, second only to opiate overdose. 10,200 deaths each year are the direct result of an eating disorder. That's one death every 52 minutes. About 26% of people with eating disorders attempt suicide, and the economic cost of eating disorders is $64.7 billion every year. Now we're going to discuss treatment. How does a professional go about treating this psychosomatic disorder? Well, treatment must include helping the eating disordered person to gain insight into their thoughts and behaviors and finding other, gentler ways to cope with anxiety and unpleasant moods without succumbing to an eating disorder. Many psychological therapies and techniques ranging from distraction to mindfulness can be employed depending on the age of the patient, their degree of emaciation, the length of their illness, and their personality and resilience. Interaction with other patients as well as with recovered sufferers can be reassuring and supportive as well. The following charts provide the most frequently used types of therapeutic interventions in treating eating disorders. First noted here is supportive psychotherapy, where the therapist provides reassurance, advice, and guidance and encourages the patient to take responsibility for change. Encourages expression of feelings and emotional material, helps the patient to understand what is happening, examines the patient's individual problems and needs, aims to teach strategies for coping with different, mainly stressful situations without relapsing into old behaviors, provides intervention when crises occur. It's the main therapy during and after most other interventions and is mainly used as individual therapy. Then we have cognitive behavioral therapy, or CBT, which focuses on bringing about changes in negative thought patterns, identifies the beliefs of the person that influence how they experience and deal with daily living, helps the person to understand how these beliefs affect their reactions, helps the person understand how these beliefs help to maintain their disordered eating, challenges these beliefs by doing behavioral experiments used in individual and group therapy together. The next is family therapy. It's useful for treating eating disorders in young people ages 16 years or younger. The assessment of the family and partial involvement in therapy should be considered in older patients, particularly if they are still at home. The aims of the therapy are to, 1, help the therapist and the family understand the family dynamics and reasons for the eating disorder. 2, to help family members develop an understanding of the behavior of the eating disordered person. And 3, to help the family learn how to provide support for the sufferer in the recovery process. The next one is acceptance and commitment therapy, which assumes that many psychological problems and feelings result from fear. And this helps people accept their reactions and feel them rather than not try to avoid or change them, including old and new experiences and trauma. And it also promotes the recognition and clarification of personal values and acting on these, creating a meaningful life. Then we also have interpersonal psychotherapy, or IPT, which are therapy sessions focused on one of 4 interpersonal problem areas: grief, role conflict, interpersonal conflict, and social deficit. These therapy sessions concentrate on depression, which occurs as a result of a problem in one or more of the above-mentioned interpersonal conflict areas. IPT is one of the few empirically validated types of psychotherapy which addresses the problem, helps insight, and promotes action and problem solving. This is typically used in short-term individual therapy, which is typically 12 to 15 sessions. The next is dialectical behavioral therapy, which is DBT. It sets boundaries for behaviors, promotes balance between acceptance and change through regular monitoring of behaviors and emotions and cognitive states, promotes mindfulness practice and improves skill at managing emotions, promotes improving interpersonal relationships and toleration of distress, and used in individual and group therapy, often for those who have a personality disorder as well. The next is mindfulness-based cognitive therapy, which focuses on teaching coping strategies for staying in the present moment or situation when exposed to unpleasant emotions, teaches how to be mindful of thoughts, thinking patterns, and behaviors, and to use this mindfulness to go through a certain situation or emotion, aids the learning of relaxation and mindful eating, and this is typically used in an individual or group therapy setting. And the last one is schema therapy, which assumes that maladaptive coping skills or schemas relate to childhood experiences, helps the individual gain insight into their feelings and learn new ways of coping, helps people find constructive ways of having their emotional needs met, and then also helps them to adjust and accept earlier experiences. Now I'd like to take a few minutes and show you this very interesting and educational clip on the neuroscience of eating disorders.
Food is a basic necessity of life. We literally can't live without it. But our relationship with food can be complicated. So the existence of eating disorders isn't really that surprising. Hey there, I'm Allie Astrocyte, and in this episode of Neurotransmissions, we're gonna get a little bit heavy. Eating disorders are a difficult and serious topic, but this week we're going to talk about some advances scientists have made in understanding these disorders in order to develop better, more effective treatments.
Yes.
The term eating disorder actually covers a broad range of conditions. The 2 most commonly depicted in popular media are anorexia nervosa and bulimia. Anorexia nervosa is characterized by extreme caloric restriction. People who suffer from anorexia usually maintain strict control over what they eat, eating only a few hundred calories per day, if they eat anything at all. Because of this, people with anorexia frequently show extreme weight loss. Bulimia usually entails cycles of binging and purging, eating a lot of food, then making themselves vomit, using laxatives, or exercising excessively to purge their bodies of the calories they've just consumed. Bulimia can be harder to see because often people with bulimia maintain a fairly steady weight. These disorders affect mostly young women, but they're becoming more common in men too. And these aren't the only 2 eating disorders out there. There's also binge eating disorder, where an individual loses control over their eating and consumes far more calories than recommended in a short period of time. This can lead to obesity and other related health problems, and it doesn't discriminate. Both men and women experience binge eating disorder at about the same rate. Eating disorders are no small problem either. About 30 million people in the United States suffer from an eating disorder. That would be like all of Boston, Houston, Chicago, Phoenix, and San Francisco combined. Many people may have the misconception that eating disorders aren't really disorders at all, that they're really just a reflection of the vanity or greediness of an individual. But in reality, eating disorders are serious psychiatric illnesses recognized by doctors and psychologists. And it turns out there's some pretty interesting neuroscience going on too. One of the things that makes eating disorders so serious is that they're very hard to treat. Up to 1/3 of people who receive treatment for anorexia end up relapsing. And many of those who recover physically still struggle with obsessions about their weight and food intake. A study published in the summer of 2015 found out that part of why recovery is so difficult may be that anorexia and other eating disorders aren't a case of strong willpower or picky eating. In fact, anorexic behaviors seem to become habits. so deeply ingrained that sufferers aren't even aware of their food choices. This particular study used functional magnetic resonance imaging, or fMRI, which uses blood flow in the brain to help scientists track brain activity changes. 21 patients being treated for anorexia nervosa, along with 21 control participants, were asked to rate food on a scale from 1 to 5, where 1 was unhealthy, 3 was neutral, and 5 was healthy. They were also asked to rate food on a taste scale from 1 to 5. 1 was bad, 3 was neutral, and 5 was good. A food item they had ranked as neutral on both taste and healthiness was randomly selected. And while participants were having their brains scanned in the fMRI, they were asked to make different food choices between the neutral item and the other foods they had previously ranked. What the scientists found was that individuals with anorexia had a lot more activity than controls in a brain region called the dorsal striatum when they were making decisions about which food they wanted to eat. The dorsal striatum is a region that's associated with reinforcement learning, basically habit formation, and decision making. These results indicated to the scientists that it wasn't so much that the women with anorexia were choosing not to eat or choosing to only eat super healthy food, but rather that they were unconsciously slipping back into a deeply ingrained habit. So, it might be that treating eating disorders successfully requires more of a habit-breaking approach, like we use with substance abuse, rather than simply telling sufferers to stop acting that way. There's also evidence that other brain regions show different patterns of activity in patients recovering from anorexia in a region called the insula. The insula is a part of the cortex that helps the brain identify what it's tasting. Along with other brain regions, like the amygdala and the orbitofrontal cortex, the insula helps us identify what tastes we like and don't like. More activity is seen in these regions when we're hungry and less when we're full. These brain areas, along with the ventral striatum, help determine how motivated we are by food. When individuals with normal eating patterns are given a sweet-tasting stimulus during brain imaging, there's a lot of activity seen in the insula. The more they report liking sugar, the more activity in the insula. On the other hand, patients who are recovering from anorexia show lower levels of activity in the insula, which might indicate that they find the sugary taste less pleasurable than their control counterparts. These individuals appear to actually experience taste differently, even after recovery. Scientists interpret this as indicating that people who suffer from anorexia are less driven by hunger and appetite signals than usual. And with less motivation to eat, it may be easier for these individuals to drive themselves to the edge of starvation. Researchers are still working to understand the neuroscience of eating disorders, and are currently limited by available scientific techniques to help them break down the biology of the brain. But these results are helping doctors and psychologists determine their approach to treatment. For example, since anorexia seems to be connected to ingrained habits, doctors now recommend that patients in recovery try eating in new places to help break the habits formed by disordered eating. And hopefully, as scientists continue to develop new techniques, we can continue to develop new treatments. In the meantime, there are a lot of resources out there to help individuals with disordered eating recover. If you or someone you know is struggling with an eating disorder, please check out the resources we've listed in the description below. Thanks so much for watching this week's episode of Neurotransmissions. If you enjoyed it, hit subscribe to become a Brainiac. And consider supporting us on Patreon if you're really excited about what we do. We really appreciate your support. Until next time, I'm Allie Astrocyte. Over and out.
Now some questions for you, the audience. 1. What type of therapeutic intervention mentioned do you believe would be most effective in treating a female teenager with an eating disorder? If you're brave enough, add in why. Number 2, what type of programs would you put in place to help prevent eating disorders from occurring in the first place? And 3, where would you implement these programs? If you or someone you know is suffering with an eating disorder, please take a moment to review this slide for numbers and sites that can help. The following references are where the information provided in this presentation was obtained. Thank you again for taking time out of your day to watch my presentation on adolescent girls and eating disorders. Before you go, if you're interested in learning more about eating disorders or prevention resources out there, please take a moment to review these lists. Thank you again and have a good night.